Hang on a second. I don't really need to share the screen for this one, but
You can open.
okay. All right. I really don't need to, well, you can have it if you want. Let's do it again. Save me keep repeating myself. Okay, so there's your patient, 29-year-old female runner. Who's complaining of retropatellar pain. The onset was gradual and insidious. The pain was severe enough to have her stop running for at least the last 4 days. It's worsening with time, the actual time she's running for, and also for how far she runs. So she's running short, or she was running shorter distances, getting more pain. So she stopped running, and basically it's sort of leveled off, and it's not giving her too much trouble now. Although it is still giving her problems. It's not as bad as they were though. There was no triggering event other than the fact that she ran 4 miles 6 days a week. And the onset of this was 3 weeks ago. Okay, so I'm your patient. You can ask me questions or do tests or whatever you want to do with me.
Okay. I mean, the first thing I want to know is if there's any history with the knee, any old knee injuries.
No.
How quickly does the pain subside after the activity?
Oh, it can take quite a while recently. It can last for, the ache in there can last for an hour or so.
Okay. I would go through a screen of the knee mobility, so overpressure, deflection, extension.
Okay, that's all the history you want though, is it? All right, I'm gonna interrupt you because I want to show you a different way of asking the questions. Last time what I did was I simply said, "Hi, I'm your patient," and ask the questions. Tend to be a bit easier at this level. So I'm going to ask you now, what do you think the problem is?
I'm thinking, I mean, the first thought that comes to mind is like chondromalacia patella, like a change under the surface of the patella.
Okay, how do you identify chondromalacia patella? If you like, what's the difference between chondromalacia patella, osteoarthrosis of the patella, and retropatellar syndrome, which really doesn't have any good pathology for it? So what's the difference between those three things? Because you're giving me a very specific diagnosis. I want to know how you got to that.
Yeah, I mean, ultimately, I guess the way I've seen them, I would think they would present relatively similarly. I would look at the age of the patient, so, and any like repeated activity that she'd have.
No, chondromalacia is a visual diagnosis. It needs to be imaged, and then the diagnosis of chondromalacia is made from the image.
That's
You
okay.
really can't definitively, yeah, you can't definitively diagnose that from clinical.
Yeah, that's okay.
So let's call it retropatellar syndrome because you really don't know what the pathology is. But you're telling me there's a problem with the posterior aspect of the kneecap and it's given a pain. Is that it?
Yeah.
Okay. All right. Prove it.
So just I mean, I'd palpate first if there's anything that I wouldn't anticipate like palpable pain.
Okay, tell me what you're palpating, would you? And I'll give you the results, but I need to know what you're palpating.
I'd start at the patellar tendon, see if there's anything tender there.
No.
I didn't think so. I would do the joint line, medial lateral joint line.
No.
From there, I would probably go to a patellar grind test like an athlete and see if that's triggering symptoms.
Okay, tell me how you're doing the grind test.
Have her contract quadriceps while I'm holding the patella down.
Okay, both knees are positive.
Both what's positive? Both knees are positive?
Yeah, I'm assuming you're doing it on both.
Yeah, yeah. And same quality of pain on both sides.
Quality is the same. Intensity
Yeah,
is
so intensity is different. I mean, that to me that indicates obviously with the intensity. I mean, and her symptoms and her presentation, some active inflammation there on the more intense side. It's an uncomfortable test in general, so I'm not surprised that it.
yeah, that's why it's not your first test.
Okay.
The chances are if you do it to one knee, they're not going to let you do it to the other knee, especially if you pick the worst knee first. You've got another, you can grind this manually.
Yeah.
Which will give you more information, and it will be positive if you need to. It'll tell you about crevice, it will tell you which part of the patella is tender as well. You get much more information from it, and you don't get stuck with this idea about both of them are going to hurt, so I'm only going to let you do it on one knee.
Sure.
It's an extremely sensitive test, but that's all it is. Specificity is a bit rubbish when you're looking at the part of the patella. Anyway, sorry, carry on. Dave, hang on. Sorry, is Mark one of your fellows?
No, he's out there fighting on his own.
Hmm?
He's out there fighting on his own. He's not a fellow.
Okay,
Should have been. He should have been. So we'll make him suffer.
All right, I'm doing the right thing. Carry on.
Yeah, so then I would, I mean, I want to, you asked about anything more in the subjective. I don't know that there's anything right off the bat that comes to mind. I would go through, I'm still interested in seeing what her active range of motion is through flexion and extension, and her passive range of motion with overpressure, see if either of those are triggering. Primarily for like passive extension to rule out tibiofemoral joint, or rule that in, see if that's triggering for her. I want to decipher between her tibiofemoral joint and her patellofemoral joint.
Okay, do a quadrant test, not flexion and extension. If you're looking at ruling out, which is what you should be doing with this
Yeah.
presentation, you're looking at ruling out, use quadrants because it's much more stressful than simple flexion and extension.
Okay.
All right. Negative.
Negative into the all four quadrants?
Yeah.
Thing?
Yeah.
Okay. Have her go, I mean, I would do a functional screen at that point of, I mean, her triggering event is running, and that's all that's been triggering over the last 4 weeks. She didn't say anything about stairs. I guess I would ask about stairs if stairs are painful, or sit to stand, squatting, anything like that has been triggering for her.
Stairs are painful. What do you expect? Up or downstairs to be more painful?
I would anticipate downstairs with eccentric quad control to be more painful. And
yeah, okay. Is there any other functional movements you want to test apart from squatting, which she may or may not do, and you know it's going to hurt? So, anything else?
Not that I can think of.
Okay. Do you know what the movie sign is?
Did you say movie sign?
Yeah.
I'm not sure that I do.
Okay, it's simply where you've been sitting for a long time, and when you stand up, your knee hurts, and then when you walk some distance, it stops hurting, or at least it gets a lot better. This is a positive movie sign. It's not pathognomic for retropatellar pain, but given all of the other stuff you're getting, that is going to be the final cherry on the cake. The other thing you should do is palpate the undersurface of the kneecap. Because if that's not tender, then everything else so far is wrong. But you palpate the undersurface of the kneecap, and you're also looking for where the kneecap's painful, the bit of the kneecap that's in trouble, because that's going to play a role in the etiology somewhat. But it's certainly
So
going to play a role in the treatment.
When you say palpate, palpate the undersurface of the kneecap, are you just doing a medial? I mean, that's limited surface area that you can actually palpate.
Sometimes it is, sometimes it's not. Depends on how flexible they are, but you can get underneath it. So you displace the patella medial and laterally. If you're displacing it medially, palpate the medial surface. Laterally, you palpate the lateral surface, and you get under as far as you can. Pretty much guarantee, though, if they're not painful, then your diagnosis is probably wrong. So your two keys there are the patella grind and palpation of the undersurface for the diagnosis. Like looking at whether it's coming from the knee or the patella isn't part of your diagnosis. That's really a bias and error check rather than diagnosis. Okay. Okay. So you're happy with your diagnosis for retropatellar syndrome?
Jim, did you say it was positive when you're palpating underneath, and then location where?
Yeah, when you hit the spot of the patella, if you can get it, you can't always get it, but if you get underneath it, you hit the underside of the patella, somewhere underneath there is going to be very tender.
In this patient, what was the finding?
Pardon?
What was the finding in this patient?
Oh, sorry. Yeah, the movie sign was positive and palpation was positive. And we'll say that's underneath the medial superior and middle facets.
So I'd be I'd be okay with that diagnosis.
Okay, now treat it.
Is this where Krista steps in, or am I?
Yeah, this is yours still. Diagnose and treat.
Okay.
That was easy.
I mean, kind of along the lines of Dave's comments, that's where I would want to see her functional movement pattern. What's happening at the ankle? What's happening at the hip to cause the increased pressure there?
No, you're not. That's etiology. I want you to treat the local pathology.
Okay.
There is local pathology. It needs to be treated.
Well, I would start with a release of the quad tendon and the quadricep.
What's the matter with the quad tendon?
I think there's probably a good chance that it's increasing pressure into the patella across the joint and increasing pressure there.
Why? Why do you think there's pressure from the quadriceps? What do you think is causing? When you say, like, how are the quadriceps causing that pressure?
I mean, so I'm thinking along the lines of a trigger point in the muscle. If there's
okay, so why is there a trigger point in the muscle?
Why is there?
Yeah.
I'm not sure.
Well, you can't throw the term around if you can't tell me why it's there. Why do you get trigger points?
To go, I mean, it tends to be overuse of a muscle, or I don't know. I'm going down a dead end here.
You are a bit. Trigger points are caused by hypertonicity in the motor. It's usually over the motor unit, but it's caused by hypertonicity. What causes hypertonicity in the muscle?
Not exactly sure.
Segmental facilitation.
Okay.
No, not okay.
That's my job, Mark.
Yes, it is, exactly. You're treating etiology. I want you to treat the local pathology.
Okay.
That's my job. Well done.
So I guess yeah, I don't know. I'm
I'll
jumping
help.
ahead.
I'll help out a little bit. I mean, if she's getting painful irritation on the back of the patella, we need to try to unload it. Check if it's being pulled medial lateral. And then I would, in this patient,
You're
I
talking
would
about
probably,
etiology again. It's etiology again.
well, but if you're
I mean,
treating the pain, you want
No,
to
you're
just,
treating
Well,
etiology. What I want you to do is
activity
treat the local
modification?
pathology. You've got inflammation back there. You've got nobody's quite sure how the cartilage actually gets painful. With chondromalacia, it's fairly easy. Nobody's too sure how you actually get retropatellar pain syndrome from a non-pathological cartilage. The area is inflamed, which is something else you should have asked me about, was puffiness around the
Okay.
patella. So I want the pathology treated. Have you learned, there's a few things you can do locally. You can do things like anti-inflammatory treatments. You can use IFC, you can use ultrasound. You've learned patella grinding, haven't you, as a treatment?
Mm-hmm.
Yeah, you can use that. There's a number of things you can use.
What are you doing the ultrasound for?
Anti-inflammatory. What do you use it for?
would you stay along the medial
I don't
border?
use it.
Well, you
Like-
should do. It works. Sorry, Crystal, what?
Would you stay along like the medial knee with the ultrasound in this case?
Yeah, I
Since
mean,
that's where the tenderness is more,
yeah, like this is why ultrasound doesn't work,
yeah.
because you keep giving low doses. I bet you use it pulsed, don't you?
I do continuous most of the
You do
time.
continuous. Mark, do you use it pulsed or continuous? You don't use it. Do you?
I don't use it.
Okay, now, how big an area do you bathe in the ultrasound?
You can only do half the size of the sound head in what, 5 minutes?
Yeah, it should be, yeah. I mean, basically, what you need to be doing is holding that fairly still. If you're doing it pulsed, it shouldn't be a problem. If you're doing it unpulsed, it's going to get painful. So you turn it down to where it's tolerable. But what you've got to do is give a high enough dose of ultrasound to make it work. If you're doing great swaths of the ultrasound, you're using it for massage. But it does work, Mark. You're just not giving a high enough dose.
Okay.
And I hate ultrasound, simply because it gets misused all the time. But when you use it right, it does work, especially on fairly acute inflammatory conditions. So locally, you need to be doing anti-inflammatory stuff. That's an inflamed tissue.
Sure. Yeah.
Otherwise, you're going to be treating the etiology. There's no point in trying to treat the quads until you know why the quads are not working properly, if they're not working properly. If the quads are working well, you don't need to treat them. If they're not working well, you need to find out why they're not working well, which is etiology again. Yeah?
Yeah.
All right. All right, Krista, etiology.
All right. So we want to figure out why this kneecap is painful. So in this
Yes.
patient, yeah, thank you. In this patient, I mean, like Mark was alluding to, we want to watch those functional, kind of look at her functioning. If her pain is mostly present with running, I want to see kind of what her running pattern looks like. I mean, obviously I can't do that right now while it's still bothersome. But are we assuming we're kind of at a point with this patient where we've calmed her down enough to?
No, you're not. This is treatment etiology. This is diagnosis.
Okay, so I
etiology.
would watch her squat.
That hurts, and she doesn't like doing it.
Okay. Where at in the squat? How far is she able to get before the pain comes on?
She gets to about 90 degrees and then it starts to hurt.
Okay. I want to look at strength testing.
All right, I'm going to interrupt you. What does that tell you that you can use?
Well, like that her squat is painful at 90 degrees.
And
It's giving you kind of the contact point of where on the patella she's.
you already know that, you palpated it.
Oh yeah, that's true. I guess if it's not happening immediately in the range of motion, I don't know, maybe I'm less
All right.
concerned with the hip.
Functional tests have a limited ability to tell you about the patient at this point.
Okay,
Okay. What you've got to do is you've got to be thinking again in systems, not in detail.
okay.
What etiologies are you going to be looking for? Not specific to this case, but in general, what etiologies do you look for?
Segmental facilitation.
No, generalized, much more general.
Are you asking like just other joints? Like,
No, no,
Mechanical, neurophysiological.
that's it. Yeah, mechanical, neurophysiological, neurological.
okay.
I
Yeah,
mean,
yeah.
that's your mantra: neurological, mechanical, neurophysiological. Now, in the lower limb, the biggest cause is going to be mechanical. The forces there are so great that the mechanical stuff really does dominate the neurophysiological, neurological, whereas in the upper limb, it's the other way around.
Okay.
So you can start wherever you want to, but I think you're going to get more production out of this if you look at mechanical causes.
Okay.
So what stresses on the knee will produce painful quadriceps, painful patellas?
Oh, I guess I don't understand. I mean, flexion extend. I mean, the knee is a flexion extension. Is that what you're asking?
No,
Okay.
the patella actually isn't really a flexion extension. It doesn't really move very
Well,
well.
it compresses, I guess. The quad compresses it.
Up to a point, but not when the knee's straight, it doesn't. It pulls it upwards. Actually, it can't really pull it up because the tendon's not that elastic. So it really can't go very high on your knee. It can go lower on your knee, but it can't go high on your knee.
I'm not sure what you're asking at this
Okay.
point.
Have
Like,
you got a
what-
single test that will tell you that the patella is likely to be in trouble? One test. And what might be causing the problem?
I don't. I
Q
honestly don't.
angle. Q angle.
Did you say ankle?
Q angle.
Oh, Q angle. Sorry.
I mean, that tells you if you've got an excessive Q angle, I would do it in standing if I was you. If you've got an excessive Q angle, it means you've got a valgus force on the knee.
Okay.
It means that the patella is pulling laterally on the, you haven't got balance forces. The patella is pulling the kneecap laterally because it wants the bowstring, and that brings it into contact with the lateral condyle, which increases the pressure on the lateral side. But you've now got a valgus knee. So the Q angle is your gateway test into this.
Okay.
It just tells you that the knee has a valgus force action on it. And now you've got to figure out why there's an increased Q angle.
Okay.
So why is there an increased Q angle?
Well, that's a great question. I'm going to look at the hip and the knee, or excuse me, the hip and the ankle
For what?
to see, I mean, posture to start with, or kind of, greater trochanter. I want to see where it's sitting within the innominate to see if the hip is anterior or not sitting where it needs to. That's obviously going to throw off the position of the knee with running.
No, I'm talking about the Q angle now. Like, you really can't do what you want to do here. You can't look at the trochanter's position and say this one's got a 10-degree adversion or a 5-degree adversion. Not with any reliability. You need coarser measures than that. And little changes there really won't bother the knee that much. You want growth causes of increase. What will increase the valgus of the knee? That's really what we're talking about here. What will increase the valgus of the knee to a large extent?
Are you talking just muscle tone?
That won't increase valgus. Valgus is a non-physiological movement caused by stress.
I'm just lost on what is being asked right now, because I feel like if we're looking for mechanical causes, aren't we looking at other joints?
Yes, you are, but I'm telling you, this is a gateway into them. All right, hold on a second.
I'm sorry. I just feel
That's all
like
right.
I'm not sure what I'm being asked to look at, because if I mention the hip and looking at the hip or look at the ankle, then you said no to that right now.
No, because I started you on the road of the Q angle because there's a good reason to do that.
Okay.
Let me have a look here. Oh, sorry, silly bugger. Right, can you see that? Is that up, Dave?
We can see, yeah.
All right, so look. All right, this is your Q angle. Innominate, knee, foot. So you got line going from there to there, yeah? And your Q angle is basically that's medial. Your Q angle is basically that, isn't it? Yeah. So what will increase that valgus is a flat foot.
Right.
So one of the places you're going to look at is the foot. The other thing that will do it is the valgus instability. The ligaments are torn or incompetent. Yeah. It can be the innominate going laterally. Well, that's a very minor cause of it. It can be a long leg, because a long leg will do exactly that. It will give you a valgus force. So that's why you look at the valgus, because it leads you to looking at other things. It's a screening test for what you're going to be looking at. You just don't go blindly and look at the foot, look at the hip, look at the back, and so on. You let the mechanical side of this tell you. Do you see how this is going to cause a problem? Because this is going to bowstring from there to there. It's going to pull the patella laterally, and the bigger that Q angle is, the bigger that it's going to pull it out. And there's your forces. So this is what actually causes it. Because you've got a Q angle doesn't mean to say you've got a knee problem, patella problem. But most people with a patella problem will have a high Q angle. Not always, but often. Condylomalacias may not, because it's a disease process. But these retropatellar syndromes will usually, and that will lead you on the path to looking for your etiology, not just a random search of things.
Okay. So you're saying
it's coarse grained, so you can pick it up easy.
So you would have this patient, you would put this patient in standing just to kind of screen, look at, okay, she has increased varus.
Yeah, you measure it.
Or valgus, excuse me. Yes.
You measure from there to the patella, from patella pole, and through the patella there. For the tuberosity, tibial tuberosity. And then basically that gives you the Q angle. If you do it in non-weight bearing, you don't get the effect of the foot. So you only get part of the picture if you do it in non-weight bearing, which is the way most people do it. It really should be done in weight bearing. That takes you to the next things you want to look at, rather than this random hunt around looking for things.
Okay.
All right, so let's do this then.
All right, so
let's say the first thing you think of is a long leg may be causing a Q angle.
Okay.
But it does. Now what? How do you determine whether there's a long leg present or not?
Watch her walk.
Okay, you're looking for what?
Vaulting.
Okay. When you watch a walk, there is no limp. It's pretty even. Not much going on there.
Okay. I guess at that point I'm not going to assume, but I'm going to keep in mind that she's at this point compensating for a long leg. since she's had this pain going on for a while.
Okay,
So I would then look at her rotating, like axial rotation, and see what's happening at the foot.
okay. The foot on the affected side is actually arching more.
Okay. When she's rotating.
When she's rotating, I've got to figure this one out. Hang on. It's when she's rotating away from the affected leg. So if it's the right leg, it's when she rotates to the left. So she's getting a bigger decrease on that left foot. The left foot is going flatter.
The left foot is flattening more than the right foot when she
Yeah.
rotates to the left.
Yeah.
Is that what you're saying?
Yeah.
Okay, I gotta stand up now because okay. I would then, I mean, at that point with this patient, I would probably go to actually assessing the subtalar joint, talar curl joint. I'd do a talar swing test first.
Okay, I'm just going to see how far I can push you with this.
Okay.
Why would that arch on that side over flatten the way it is?
On the opposite side.
No, it's on the same side. It's when they rotate away from that leg though. So if it's the right leg, the right knee they're having trouble with, it's when they rotate left.
And you're saying the right foot is over flattening?
Yeah.
Oh, I'm sorry. I had that backwards. Okay. So when she's rotating left, the right foot is over flattening. So it's trying to get to the ground.
Yeah.
If she's flattening, then that right leg would be longer or trying to be longer. See, that's what I don't know.
Actually, if you're twisting away from the right side, what's that right leg trying to do? Normally.
Should be getting. Oh God, you guys. Why
Say it, don't
hard?
hesitate, don't think you're wrong necessarily. I'll tell you if you're wrong. Say what you're thinking.
It's shortening.
It wants to shorten, yeah.
It wants to shorten.
Yeah. The other leg wants to lengthen. It's just the way the twisting works here.
Mhm.
So what it's doing is the foot is over flattening on that side, so something's stopping the leg from shortening. Probably the
Okay.
ankle. It's probably the
Okay.
ankle. Could be
Yeah,
something.
right.
You're right.
Then-
You look at those, but you need to know why you're looking at them as well. All right.
Okay, I see what you're saying. So yeah.
Okay. So the ankle
Mm-hmm.
on that right foot is subluxed, so it cannot dorsiflex.
Okay.
Why has she got a normal gait?
She's compensating at her knee is becoming painful
Well, yeah. Why?
because she's trying to make that leg longer by
That's not my question though. Why is she walking without a long-legged gait?
she probably has compensated and shortened the leg elsewhere in the
Okay, she's overcompensated. Compensation says there's no damage done. Overcompensated means you broke stuff.
Okay.
All right. Yeah, that's right. That's good. That's good. So where are you going to check for the overcompensation?
Did you say where or what?
Yeah.
Yeah, where? Well, at this point, we know the knee is painful. So then I would come up to the next joint, which would be the hip and SI joints.
Okay. What do you expect to find at the hip?
Oh, I have to think. Okay, at the hip, that she would be externally rotated.
Does that make
So that would shorten the leg, right?
yeah, but how often do you see that at the hip?
That's a great question. Not
often.
often.
You can look at the knee.
All right, let's look at the knee. I would do ligament testing at the knee.
Yeah, yeah. So you're going to see if the medial ligament's incompetent.
Yeah.
Yeah, and it is.
Okay.
So that's your breakdown, and there may be others going on. And there
Okay.
may be another reason why the leg is long as well, rather than just the ankle.
Mm-hmm.
Okay, so let's say that you found all the mechanical stuff. You found that the ankle is subluxed. Hmm?
Oh, I think somebody else jumped on.
Yeah, Tim, wasn't it?
Yeah, I think it was just accidental.
All right.
Carry on.
So,
Medial ligament laxity.
yeah, no.
Breaking down.
I mean, I stay at home to get bossed around. I go away, so I'm not bossed.
Sorry. I just have to make myself sound confident, right?
Carry on.
Carry on. We're good here.
All right, so yeah, medial collateral ligament's gone.
Okay.
And anything else you want to check? Let's say that's your mechanical causes done. What else?
Yeah, so I want to know what her strength testing looks like. I want to see if there's a potential.
Okay, there are other tests you can do for looking at tracking. Do you know what they are?
Not specifically. I guess I am used to just palpating the patella as they're contracting the quad.
Yeah, no, you do it from, you actually sit them over the edge of the bed, palpate the patella, and then get them to extend their knee, and you follow the course of the patella. So it should go medial and lateral. So you form a C shape here, lateral and medial, lateral and medial. So you form a C shape, and that's what it should do. Not just the strength of the quad. You're looking at whether the valgus medialis is kicking in or not.
Mm-hmm, right.
You also do a weight bearing test where you don't do these where you get them to squat over, see where the knee is tracking over the foot, should be second or third metatarsal, and then you ask them to spread the knees without rolling onto the outside of the foot, and they should be able to bring the knees out past the fifth metatarsal. That tells you basically whether the foot's doing its job or not.
Okay.
People
Is there a name? Is there a name for that assessment? Is there a name for that assessment?
There's weight bearing tracking and non-weight bearing tracking.
Okay.
They're the only names I've known by. So people will tell you that's the hip can't laterally rotate, but the hip's perfectly capable of laterally rotating. If you lay them on the bed, you can rotate it everywhere, but it's a foot that can't do its function. Do you expect the weight bearing test, tracking test in this patient to work normally?
Do I expect it to be normal in this patient?
Yeah.
No.
Why?
She's had this pain for a long time.
Now it's not based.
And
this
we're
isn't about pain. She's not getting pain.
I mean, I guess at this point, because of the breakdown that we're seeing.
No, it's because of the ankle subluxation.
Oh, right. Okay.
Can't forget things. But they're your first tests. Before you go looking at big pathology, few angle, non-weight bearing, weight bearing tracking.
Okay.
And that'll tell you where to look. So let's say the weight bearing tracking is going to be off. Let's also say that the non-weight bearing test is also positive for that right knee. So it's being pulled too far laterally. Okay.
Mm-hmm.
You can test the strength of the quads. How are you going to do that?
Prone.
Okay. And I'm going to say that the quads in that position are slightly weak.
Okay.
All right. So what's the other thing that you need to have done, or you can do now actually, for the etiology, as far as the quads are concerned?
Reflex testing?
No.
Oh. Oh, just over pressure and knee flexion.
Now they shouldn't hurt much anyway. It won't hurt the quads. No, is there atrophy there?
Okay,
Particularly the vastus medialis,
right.
because they atrophy quickly. So you can have fairly profound weakness of the vastus medialis, and the bulk of the quads is not bad. But it's
Right.
tough to pick up the vastus medialis without palpating for atrophy and without doing that tracking test. Because you test the whole quads.
Yeah, right.
Yeah, so make sure you're palpating the vastus medialis when you're doing extension. So why are the quads weak?
I need to find out.
You need to
You said that they're
hypothesize first. No, you don't need to find out. You need to hypothesize first.
okay. If you said that
Well-
they're slightly weak, but I'm not hearing any fatigable weakness or breaking
I
weakness.
didn't give you the quality of it.
Okay, what is the quality of the weakness?
Okay, it's when you do it in the prone position, it's a breaking weakness.
Okay,
Why would that be there?
reflex inhibition,
Okay, so what else do you expect to find around the knee?
that other knee
Okay,
testing
good.
would also be
So you're
weak.
looking for patterning, yeah.
Mhm.
Okay, good. So where's that breaking weakness coming from?
Would that just be the inflammatory
Yeah,
condition?
it's coming, it's almost certainly coming from the knee, yeah.
Yeah.
Now, could he also have, or she have, segmental facilitation?
Yes, she could also have that.
Okay, so what are you going to do about that? How are you going to find it?
Well, I could do, I mean, I could wobble L3, 4.
What are you going to be testing for if you do that?
To see if her strength in the quadriceps improves.
Not really, because you know that that's breaking weakness.
Okay. I'm not sure.
Well, how do you find out whether somebody has segmental facilitation in general?
I mean, you look at the other segments to see.
Yeah.
I mean, what we've been taught, at least from Eric, was we would find a velocity dependent weakness, and then we look at other segmental.
Well, you look at segmental stuff first. Like
Okay.
you're going to, if you're thinking this now for segmental facilitation, look in the spine. All right, you're going to have
Oh, multifidi.
hypertonus up there, yeah,
Yeah.
at L3. You can look at hip flexion, which is not L3, but it takes in some of the L3. L3 is a difficult one because it's the only one available.
Jim, at what point would we expect that the multifidi would start to atrophy? So like how long in an injury state would you see hypertonus?
No idea.
Okay.
I don't know. The studies that they've done on this, the amount of atrophy that occurs there
Mhm.
is variable, anywhere from about 5% all the way up to 50%. How long it takes probably depends on the intensity of the signal as much as anything else.
Okay.
No, I don't know. But you're not looking for atrophy. You're looking for hypertonicity.
Okay.
Yeah.
Yep.
Then how do you find out where the segmental facilitation is arising from?
Asking me?
Hmm?
A mouthful of cookie. I'm sorry.
Did you hear that, Chris?
No,
How
I'm
do you
sorry.
find out how do you find out the source of the facilitation? The knee's probably contributing, but you like if
Oh,
you're
I see.
to
So
argue that
we're saying L3, we see facilitation at L3, and how do I know what is causing the facilitation?
is
I
it
look
coming
for the
from the
pain.
spine, the hip, the knee?
Yeah. I mean, we're looking for the painful joint, right? Or
Yeah.
the pain producer.
Yeah. Yeah, so you want to produce nociception in these joints.
Yeah.
And then there's a possibility that's called it, but you can never really prove this. If you find the pain there, though, you go and look for biomechanical dysfunctions, and that may or may not be part of your treatment. Yeah.
Okay.
Because everything might be coming from the patella, the reflex inhibition and the segmental facilitation.
Mm-hmm.
And none of them are causes in that case. Or the facilitation could be playing into the retropatellar pain problem. But it's unlikely that the reflex inhibition caused the patella problem. Possible, but you didn't find anything wrong with the knee itself. Yeah.
Right. Other than the ligamentous breakdown.
Yeah.
Okay.
So you can't be sure about this stuff. So you either treat it or you don't treat it.
Okay.
But if you treat it, you treat everything that may be causing that facilitation or that reflex inhibition. Okay.
Okay.
All righty. Again, my comment here is organize the way you're processing
Yeah,
stuff.
for sure. For
You know,
sure.
don't go jumping in and say, I'll try this, I'll try that. Like, predict what you're going to find from the pathology. This is etiology now. You know what the diagnosis is. So now predict what you're going to find in the etiology search. And then make sure that search is organized. You're either going to look at the mechanical causes or you're going to look at neurophysiological causes, neurological causes, but don't mix them up because you're going to get confused as hell if you do that. But don't stop when you find a single cause. All right, keep looking. Is that okay?
Yeah.
All right, I'll offer you two the same thing I've done with the last two. If you want to go over this, was that thing useful to you, that the explanation I did on the video that Dave sent out?
Let's see if Dave sent that out. When did you send it to me?
Tanner said he got it.
Good.
Yeah.
Oh, you know what?
So
I may
you
have
got-
sent that to Tanner and then I sent it to everyone else. I'll get it out to everybody. I sent
Okay.
it to Tanner and Michelle.
Yeah, fire it off to everybody.
Yeah.
Okay.
I would have been like 25% better had I seen the video, I'm sure.
Yeah, all right. We'll let you have that. Okay, but one of the things to take from this is you see how it's different when I'm talking to the certification group, to the fellows. The expectation from the fellows is much higher than it is from you lot, although the expectation, as you can see, is still high. But I'll give you a chance to sort of work through your thinking with
Yeah.
me. And the way I mark it then basically is, how much intervention do I have to make? If I'm making 90% of the intervention, I've just passed that exam. Yeah. So that's the way I tend to work it. With the fellows and with the M9 exams, it's almost distraction testing. How far can you take this? And can I take it a bit further? Yep. Okay, does anybody have any questions on what we did today?
Yeah, Jim, summarize the order of the thought process for this case with the patellofemoral pain. You know, how I organized it may be slightly different than you. Just, you know, where would you have had a Mark start?
Okay, I want to start with the
As a person
diagnosis. I would have done a groin test and palpation. They would have been positive or they've been negative. If they've been negative, I would have done something else. It could be referred from the hip or the spine.
You had started with a differential diagnosis of, okay, I think this is patellofemoral, and tested those two things.
Well, the presentation says it's retropatellar, so I would prove that or not. They are divided between referred and tibiofemoral joint by doing quadrants on the knee. If the quadrants are negative, it's referred. If they're positive, they've got a knee problem.
Okay.
So I'd make the diagnosis. From there, I look at the mechanical causes of retropatellar pain. Q angle, big one for me. Q angle, is it high? If it's not, it makes things a lot difficult. Let's say it's high though. Then I'll do tracking.
Now, Jim, when you say Q angle too, you're not referring to static measurement. You're looking at standing Q angle.
Yeah. Yeah.
Okay.
Otherwise, you lose the influence of the foot in it.
Yeah.
Yeah. So Q angle. If the Q angle is high, then I've got some choices. It's either because there's a short leg because the foot's collapsed, and it's caused that medial rotation valgus force, or it's a long leg coming in. So you're getting overcompensated by hyperextension and valgus. There's one of those two things. I'd probably look at the gait first. If the long leg's present, I'd go looking for causes. The big ones are ankle and hip.
Mm-hmm.
If they're not there, then I'd be thinking short leg because of a collapsed foot. Not that the short leg causes the increased Q angle, but the collapsed foot does, and that causes a short leg. So again, the leg length is just an indicator. So I would then examine the foot. You've got twisting's good. Toe raise, flat foot squatting, and so on. So they're all good tests, but then you test it out biomechanically and see what's happening there.
That's where they do the squat test early on when he's looking for his diagnosis. The squat test, my thought would be more valuable
I'm
in
not
this
looking at it
phase.
for the knee though, and I'm not looking at it as a diagnostic purpose for the foot. It's a screen, basically. So having found that, say it's a long leg, I'll then look for the EGRs of a long leg. Again, if it's a foot that's collapsed, I need to know why the foot's collapsed. Now it's possible that they actually have equal leg lengths because the foot has collapsed. So it started off with a long leg, the foot's collapsed, so now it's a short leg, and the whole thing is rotating and putting that valgus force on it. So a lot of this is about interpreting what you find, not just looking, but interpreting what you're finding. If I've got the cause, let's say I've got a hip subluxation and an equal gait and an overly flat foot, then that flat foot has occurred because of a long leg. That leg, if the foot wasn't flat, the leg would be long. So you're retrospectively saying this is a long leg, even though the gait says the leg length is equal when they're walking. Mm-hmm. There's not that many variables, but you really do have to think about this. There aren't that many variables. You either got a long leg, a short leg, an equal leg. That's it for the gait. Mm-hmm. So if you now go looking at the biomechanics in the leg, looking for a cause of a long leg or a cause of a short leg, that will tell you what it was when it was before it overcompensated. Maybe.
And I guess even in this individual, again, I expect you're going to find one of these things occurring in there. When we describe it, the flat foot, the lax MCL, that's kind of a person that I see a fair amount.
Yeah.
Even looking at this person, if you look at walking and then running, the forces going up with those activities would increase those rotary forces going into the knee.
Yeah, well, it's going up and down, isn't it?
Yeah.
You're getting body weight coming down, ground reaction forces going up. And it takes a beating. The knee is what takes the beating. It is the knee. It takes a hell of a beating right in the middle of it. It can't compensate. Anything away from your regular standing position, whether it's hyperextension, flexion, abduction or adduction, valgus or varus, is going to shorten the leg. Mm-hmm. It's got very limited ability to compensate. So it breaks down.
So you may find a few laxities here. You may not find a subluxation, but this woman who runs with this increased rotary force, this dynamic, Q angle or valgus, is going to put a ton of stress through the knee joint. Yeah. So it's kind of like you have to kind of get a sense of where all these joints are, and they may or may not be subluxed. But understanding what they should do and what they are doing, then once you add forces on top of it, you have a kind of a more complete picture. Yeah, it gets messed up. It really gets messed up. And it's like there's not a lot of the joint itself isn't well, it's not like the hip, it's not like where you've got big congruent surfaces. These are flat bloody surfaces. Even the femur's flat in the standing position is a flat surfaces. So you're entirely dependent on ligaments. Muscles can't do it, it's all about ligaments. This is, you see this in this patterning too. You'll see that even strengthening, like, they'll show that, 6 weeks of strengthening does not improve running grade or decrease these rotary forces or this dynamic Q angle. It gets into, again, motor control or what's causing that loss of control.
Yeah. The problem with the researchers is they don't look for the cause of the Q angle. Let's just strengthen the quads and the hands and we'll see what happens at Q angle. They don't deal with the cause of it.
Mhm.
Okay, was it educational? Are these worthwhile doing these with you or not?
I think so.
I mean, this is not just testing you, this is giving you an idea what the test is like, but it should also be instructional. So you see where you're weak and so on. We're not going to get test everybody, of course, but pick up. You can learn by other people's examples.
It's good because this is the like a very common patient or female runner that I would see.
Yeah.
Would have one or some of these factors in there between. You'll find the laxity in the knee that's non-painful, it's degenerative, the rotational forces that aren't controlled. You'll find some elements of these in a lot of people that you'll see with these conditions. And which elements that we just all talked about do they have more? Is this a foot driven knee or is this a hip driven knee? Or is it coming from somewhere else?
Well, and I think it helps when you say like just being systematic about how you're approaching it and then why you are, because I think where I struggle still right now is I'm automatically looking for those etiologies rather than necessarily guiding my search.
Yeah.
I'm just, oh, okay, I need to look at the ankle and I need to look at the hip because the knee is a problem, rather than saying, well, why am I looking there? What am I finding that's guiding me to say I need to look closer at the foot? So that's where I need to step up and,
And that's a diagnosis. Everything is diagnosis. Your treatment and your etiology search. Everything is diagnosis. Anyway, you two, Mark and Krista, if you want to do a quick Zoom session, talk about this specifically, email me and we can set it up, all right?
Yeah, that sounds good.
Okay. All right, well, I'm done. Merry Christmas, everybody.
Merry
Christmas.
Christmas.
Thank you. Dave, Merry Christmas to you and your family. Take care, all.
So you have Christmas in Mexico. Good.
Yeah. Oh, I refuse to have another Christmas in Canada. I'm not doing that again.
Yeah, I can understand that.
I'll do it when I have to.
All
All
right.
right. I'll talk to you, mate. Have a good year.
Take care.
Bye.